Renal path, we'll review quickly and then go on to therapeutics. So here is the typical light microscopy, which has been introduced and reinforced a couple of times. So hopefully we can proceed pretty quickly. The most common finding is one of mesangial expansion and varying degrees of mesangial hypercellularity. However, there can be degrees of endocapillary hypercellularity and crescentic forms as well on pathology. But once again, mesangial expansion and hypercellularity is the most common feature of IgA nephropathy. And here would be an example of this mesangial hypercellularity, as well as expansion here in this lobule of this glomerular tuft, indicated by the arrows. Okay. Moving on to the immunofluorescence, which is a diagnostic feature of IgA nephropathy. I'll make a couple of points. As the name would imply, or as intuitively you might expect, IgA nephropathy would have IgA present on immunofluorescence. But what may be not so intuitive is that it may not be the dominant, it may not be the only immunofluorescent component, signal that you see. You can see the criteria requires that IgA be either dominant or co-dominant in representation in the immunofluorescence microscopy. So you can have equal parts of IgG and IgA that's present and still satisfy the criteria of a diagnosis of IgA nephropathy. Okay. We've talked about the various steps to pathogenesis in IgA nephropathy. Without scrolling backwards, I'll just reinforce the fact that there is an autoantibody that is typically IgG directed to this galactose-deficient IgA molecule. So it should be of no surprise that I see some IgG, not uncommonly, on immunofluorescence microscopy in cases of IgA nephropathy. C3 is present as well in some cases, or many cases. So you'll have to understand that by recalling that IgG can activate complement through the classical pathway of complement activation, but IgA can also activate complement through an alternative pathway of complement activation. And remember, C3 is where both the classical and alternative pathways of complement converge. And so again, it should be of no surprise that there's some C3 present at tissue level, but I'll have you recall that your circulating complement, I'll ask, Kelly, what would you expect the circulating complement to be in a case of IgA nephropathy? Low? If so, which would be low? What would you predict you would see in IgA nephropathy? No, so this would be typically normal complements in IgA nephropathy. Remember, in order to activate complement in the circulation, you need predominantly IgG or IgM in large quantities circulating as large macromolecule immune complexes, because these are primarily IgA-containing circulating immune complexes. Yes, there is some IgG, and IgA is not efficient at activating complement, not nearly as efficient as IgG and IgM. You do not have depressions of circulating complement. So you'll have to reconcile those two facts. IgA can activate complement inefficiently through alternative pathways. IgG, which is present in these immune complexes at the tissue level and in circulation, can activate complement. You see complement at the tissue level, but you do not see depression of circulating immune complement. Okay, so again, think deeply about that. We've gone over that a couple of times. My goal is for you to not memorize complement patterns, but to understand and intuit complement patterns. So go back to those first principles we've talked about a couple of times. Envision again, IgG and IgM, if they're circulating in large macromolecule immune complexes, those are the instances in which you would expect to see complement depression. For instance, the rheumatoid factor of MPGN and cryoglobulinemia. It's an IgM, very efficient at activating complement. So you would expect to see depressions of C4 and C3 not uncommonly in, for instance, cryoglobulinemia related to a mixed cryoglobulin. Okay? But I'm going to keep going forward. Can't keep going backwards. Please review those concepts. Treatment. So we are wanting to, lower proteinuria, stabilize GFR. Remember, we've gone over prognosis in our previous conversation and how important proteinuria is for predicting prognosis. The cut point for prognostic divergence is proteinuria greater than or less than 1 gram per day. Remember, the cut point for prognostication in the idiopathic nephrotic syndromes, what is that cut point, Pranav? Where you clearly see a difference in outcome in an FSGS patient. So idiopathic nephrotic syndrome includes, no. Come on, guys. Let's go. What's your idiopathic nephrotic syndromes? Minimal change. FSGS. And membranous, I heard. Okay. All right. So the cut point of, or the divergence in prognosis happens at a threshold where you say, I'm going to immunosuppress this patient. Would you immunosuppress a membranous patient with 0.5 grams per day of proteinuria? No. So you knew the answer to that. So where is that decision point? Okay. 3 despite antiproteinuric interventions. Okay. So that's where that divergence occurs. That's the decision point of where I start to treat. Okay. In IgA nephropathy, this divergence of outcome happens at 1 gram per day. Okay. So similar to these critical cut points in membranous nephropathy, etc., and the idiopathic nephrotic syndromes, where it's around 3. In IgA nephropathy, it's around 1. Okay, so that's what you're trying to do. Optimize antiproteinuric interventions. And then if they're still over 1 gram, that's when you start thinking about heavier hitting interventions. Okay, so control the blood pressure, put them on RAS inhibition. SGLT2s now are standard of care for IgA nephropathy. In fact, the biggest trials in IgA nephropathy are not with steroids or budesonide or newer drugs like iptacopan. The biggest IgA nephropathy trial is an SGLT2 trial. Okay, so that should be considered cornerstone therapy for IgA nephropathy. So include your SGLT2s. The biggest randomized controlled trials in IgA nephropathy are not steroids. It's use MPAG or not. Okay. Empakidney had the largest cohort of IgA nephropathy in any previous study that we've done in a prospective randomized trial. Okay. All right. Sparsentan can be considered. There's now a new drug that's been approved. They just keep that. IgA has been having a lot of developments in recent past. Atrasentan just came into approval. We now have iptacopan. We now have a molecule that is, I believe, now clinically available. Blanking on the drug name, but it's targeting the APRIL pathway. APRIL refers to a B cell maturation pathway. Okay, all these trials that have been happening in the recent year or two are based on proteinuria reduction, not in improvements in GFR or any sort of improvements in doubling of serum creatinine or dialysis. The budesonide trial actually showed some preservation in GFR. So I would say these other trials that are rapidly coming through the pipeline are not ready, in my view, for prime time. These are drugs that show reductions in proteinuria, but haven't shown improvements in important clinical endpoints other than reductions in proteinuria. Okay. All right. You can say that adding an ACE to an ARB also reduces proteinuria. Adding non-steroidals to somebody also reduces proteinuria. Bilateral nephrectomy reduces proteinuria as well, but obviously you're not helping your patients with these things. So again, be careful with some of these things that are tacitly approved, including, iptacopan. I prescribed iptacopan once so far. It was pretty disappointing, even though, in all fairness, it was a really last-ditch effort. The patient had not responded to anything prior to that. Okay. Again, if your proteinuria is less than 1 gram, then you're in a good place. You might consider just some easy peasy interventions, things that have no harm, like omega-3 fatty acids. Okay. The body of literature in support for omega-3 fatty acids is controversial. There was an old study that was randomized controlled trial from Mayo. That was before we even used ACE inhibitors as standard therapies for these proteinuric renal disease. And blood pressure was not ideal, and it was a positive study, but a lot of limitations to that study. Again, very old, previous to standard therapies, but this is a harmless intervention. So you can consider that this intervention, if you have somebody you really are not terribly interested in immunosuppressing. So an example of that would be someone who has a little residual proteinuria, even after optimal medical management, with non-immunosuppressant interventions, or they just have a lot of scar. You want to give them something. Fish oil is harmless, okay? And then you can also consider adding fish oil to any of the other things that you might want to simultaneously do that have greater toxicities. Okay, now if I have GFR that is reasonably preserved, that it means what I'm trying to say is you don't have dead kidney, right? If you have a creatinine of 4 and 5, it's basically CKD management. Really doesn't matter to, try any of these other things, right? As long as it's not acute kidney injury, of course, okay? So if I have only modest impairment of GFR and proteinuria remains greater than 1 gram per day, and I'm not really scarred down, you might start considering some of these immunosuppressive interventions. It seems now, based on the current literature, budesonide of all the immunosuppressants that you have is the most well supported by literature, okay? There are older studies looking at prednisone, but they're smaller than the more contemporary budesonide studies. There's also a protocol that uses methylprednisolone. Notice this pattern that looks familiar, should look familiar. Prednisolone at the starts of months 1, 3, and 5, and then prednisone at a 0.5 mg per kg every other day. What does that look like? Yeah, it looks kind of like the Ponticelli protocol. This was the same group, right? Different name. This is the Posey protocol, but same guys and gals that put together this protocol. Okay, this comes out of Italy. So that was a randomized study that was done in the space of IgA nephropathy. Again, here's a prednisone protocol, 2 months of 1 mg per kg, and then sort of taper it over about 6 months. You can see that these protocols with steroids last about 6 months. This protocol with budesonide also is about 9 months, was the actual protocol, out to 9 months. There's one more I'll highlight where you can reasonably argue for the use of mycophenolate. There was this is a controversial intervention that shows a lot of negative studies if you're not East Asian. If you are East Asian, including a recent KI randomized controlled trial that was done exclusively in patients from China, there was a benefit to mycophenolate. Okay, so with the caveat that the trials outside of East Asian populations were negative, they were all small. They were all small trials. The biggest trial was done, recently published in China, and was a positive study. So now, I used to have to include mycophenolate as just a, non-randomized controlled trial data supports this as a Hail Mary, but now there is a randomized controlled trial that supports it. But again, it's limited to East Asian populations. Okay, let's circle back to budesonide and wrap this up. So budesonide again seems to have the highest quality data at this point, I would say, even beyond some of these steroid protocols from older papers. And the budesonide preparation that has been studied is a delayed release budesonide. Tarpeo is the trade name. And the presumption is that you deliver budesonide to the Peyer's patches in the distal gut, and you modulate mucosal the dysregulated mucosal immunity that may cause IgA nephropathy. Okay, you can challenge this, and well, let's not get too philosophical. Let's just stop there. I'll just say that you can tie yourself in knots thinking about this, because people have described tonsillitis and upper respiratory infections as being precipitants of IgA nephropathy. And then you can argue, well, giving budesonide to sort of modulate gut dysregulated immunity, how does that make sense when there are these other ways that you can stimulate dysregulated IgA production through other mucosal interfaces? Okay, that aside, the budesonide studies seem to be, again, the biggest in terms of N, as well as looking at changes in GFR. And I have to say a few words about stop IgA nephropathy as well. So this is a study that looks at, again, targeted release budesonide. Budesonide has the advantage of having pretty significant first pass elimination, such that the budesonide that gets absorbed and into the portal circulation is cleared in large part by the liver, such that the systemic exposure to steroids is limited. That being said, in the randomized controlled trial of budesonide, there was more weight gain and diabetes or glucose intolerance with budesonide. So clearly there is some systemic exposure. You can't sort of rationalize away this has no downsides. Clearly there is systemic exposure based on that randomized controlled trial data. I've never prescribed Tarpeo. I've used the budesonide Entocort, right, which is used for inflammatory bowel disease, to get sort of distal delivery or of this corticosteroids in the gut, and it's worked in my hands. So we don't have Tarpeo on formulary at Parkland, and I've been reluctant to do it because Entocort is much cheaper and seems to work. That being said, I'm told Tarpeo has a pretty generous drug assistance program, and I think is manufactured in some Scandinavian country, which claims that they prioritize patients' care and make it easy to get the drug if you can. There's not a lot of barriers. Okay, I've not personally parsed that, but that's what I'm told. Okay, so real quick before I leave the immunosuppression, I have to say a word about a trial called Stop IgA Nephropathy, which was published in the New England Journal. It really challenged that. We used to be much more enthusiastic about giving steroids to patients with proteinuria greater than 1 gram. But the Stop IgA Nephropathy trial was a negative study that showed that steroids were not helpful compared to just optimal non-immunosuppressive intervention. I still think that steroids, prednisone and budesonide, do have a place in treatment of IgA nephropathy. We'll talk about in the IgA nephropathy conference. In my presentation, we can talk about Stop IgA a little bit in more depth, but it has its own limitations. Okay, but I have to give you that context. in general, the enthusiasm for steroids in IgA nephropathy treatment has declined. It's kind of increased once budesonide entered the market, though. If I have progressive decline in GFR, suggesting ESRD in less than 5 years, or if I have a presentation with RPGN, or if you've tried your corticosteroids and nothing is, and it's not working, you can then consider interventions like cyclophosphamide, more steroids, and adding azathioprine after cyclophosphamide. But these are very limited data sets that support these. I'll even transparently convey the one small study of looking at the usefulness of cyclophosphamide in IgA nephropathy, which was a JASN paper, but still small and underpowered and a lot of flaws with it, was oral cyclophosphamide. So when I'm writing here, lupus protocol cyclophosphamide, you have to accept that this is really uncharted waters. Okay, but I've used it in crescentic forms of IgA nephropathy, and I think it works in some cases. Okay, transplantation, IgA nephropathy recurrence, histologic recurrence, it happens very commonly. So when you biopsy a patient who has ESRD from IgA nephropathy for allograft dysfunction, it's very common to see IgA positivity on immunofluorescence, but we often sort of think it's really insignificant. It's really not a major cause of loss of the allograft. So again, we don't think of IgA nephropathy recurrence as being a dominant form of loss of the allograft. Okay, FSGS happens less, it recurs less, but has a much more worse prognosis than these mild recurrence rate or mild clinical significance of IgA nephropathy recurrence in transplant patients. Okay, so I've sort of punctuated this by saying the overall graft survival really doesn't seem to be adversely affected by this high recurrence rate of IgA nephropathy in the allograft. Okay. Moving on to HSP, you can see that this is just basically a couple of paragraphs or a couple of points in an outline, so not much to cover here. Let me just make a few points relating the two, IgA nephropathy and HSP. There is, some overlap. Remember, HSP is a vasculitis. Once you see vasculitis, you're really moving towards this diagnostic label as opposed to simply IgA nephropathy, okay? HSP occurs, or renal involvement, I should say, occurs in roughly 50% of patients with HSP. So what are the other 50% of patients with HSP? Those are the folks that are presenting with the classic purpura in the lower extremities, diarrhea with cramped abdominal pain and hematochezia, or joint pains. Those are the classic presentations of HSP. So 50% of those patients are having renal involvement. And then the histology is largely indistinguishable from IgA nephropathy. You see IgA dominance, you see some IgG that's present on immunofluorescence, and so it looks largely identical, although there may be more crescents that you might see in an HSP patient, particularly if you biopsy them in the setting of gross hematuria. Okay. Abnormal glycosylation of IgA is also present in these HSP patients, okay, when they have renal involvement, okay? And then also, when you have renal involvement, you'll also more likely have this autoantibody, this IgG autoantibody to the abnormally glycosylated IgA. So again, you can see overlap not only in renal pathology, but you'll see also some overlap in pathogenesis. But these patients without renal involvement who have HSP are less likely to have this IgG autoantibody production to IgA. Okay, and if you biopsy a patient who has this classic presentation of HSP, their skin, and you ask the dermatology or dermatopathologist to stain for or to perform immunofluorescence microscopy for immunoglobulins, you will also see IgA deposition there. You got to ask for it because they don't do that as standard practice. Okay. Most of the time they just do light microscopy and they see evidence of essentially just vasculitis of the skin. Okay. And you have to ask for them to perform immunofluorescence microscopy and reveal IgA on that skin biopsy. Okay, presentation. I've talked about these things: purpura, the abdominal pain, the GI bleeding. They can have this intussusception as a form of presentation as well. You can have testicular involvement. Rarely you can get CNS involvement or even vasculitis of the peripheral nervous system. And then with respect to renal involvement, you can see that remission is most common in manifestation of HSP. There is some significance to the finding of crescents on kidney biopsy. How should I phrase this? People have shown, again, crescents on HSP kidney biopsies, particularly when you have gross hematuria. So that's not uncommon to find that, but doesn't always correlate with adverse long-term renal prognosis. So what I'm trying to say is that crescents on kidney biopsy, especially when you biopsy in the setting of gross hematuria for a case of HSP, shouldn't be over leveraged. Okay, you should not necessarily say, gosh, this patient is going to ESRD unless we pull out all of our biggest hammers, because crescents do not have that impressive a prognostic value in HSP. Now, if you have florid crescents where greater than 50% of the glomeruli are involved, you do need to take that seriously. But, having one or two crescents is not something that should make you sort of panic. Okay. Recurrence can happen with respect to treatment. Steroids seem to help with some of the extrarenal symptoms, but by reducing the duration of these symptoms, you can also treat these symptoms with non-steroidals when there's not any renal impairment, or steroids. When you have renal involvement that persists, then you would consider your same regimens for IgA nephropathy.